Dr.
Good.
Mathew Ninan is a general thoracic surgeon. Sorry, Ninan, I'm going to do an intro first. And
Sure.
director of thoracic surgery at HCA Florida Healthcare West. He's a founding board member and current president of the Florida Lung Health Coalition. Please go ahead, Dr. Ninan.
Thank you so much. After those two wonderful discussions from Dr. Shulkin and Dr. Brandman, it's going to be difficult to measure up. But let me just try and talk to you something about what happens once these patients have been found to have lung nodules. What are the modern techniques we have to make this pathway as smooth as possible? And also a few words about veterans. So when we look at veterans, we've seen that they have a large incidence of lung cancer, and it is challenging. It is a very challenging patient group to see what is going on. Now, in 2007, 2008, I think, or maybe even a little bit earlier, maybe 2006, I was sent a patient from Fort Campbell, Kentucky, which is very close to Nashville, Tennessee, where I practiced at Vanderbilt University. And this gentleman had, he said, "Doc, I used to run 5 miles a day. Now I can hardly run a mile." But when we look at his pulmonary function testing, he was still scoring in the very high percentage of predicted range because he was already functioning so much above the standard patient. And he had returned from Mosul in Iraq. And then as I got to take his history, I found that he had been exposed to various smoke related burn pits and other things, and from sulfur mines also. There was a lot of smoke in the Mosul area post invasion of Iraq at that time. And so I talked with his pulmonologist, and he became the first patient that we actually biopsied for this condition back at that time. And this resulted finally in an article that was published in 2011 in the New England Journal of Medicine, which the whole team was led by Dr. Robert Miller, a pulmonologist at Vanderbilt. And we had to work through with pathology as to what the features were, etc. And we found constrictive bronchiolitis to be the major event in these patients returning after exposure like that. Next slide, please. So we had 49 soldiers. Most of them were non-smokers. Prolonged exposure to sulfur dioxide from a mine fire, open burn pits, severe desert storms, etc., could contribute to this condition. And the results showed us how environmental factors can greatly influence lung health. And I think what is happening in the general population is we are undercounting the amount of environmental exposure that we have. And the smoking becomes a huge additional factor in these patients. So this led to people like Dr. Shulkin and John Stewart and many others taking this on within the VA system and making it a something of national importance that helped us to come to the law in 2022 that has helped these patients and will continue to help them. Next slide, please. So this led to this whole field of deployment-related respiratory diseases. Next slide. And, it can occur anywhere from your nasal cavity all the way down to your alveoli. So there are multiple changes that can occur. And a lot of this have been found in veterans from various deployments abroad. So this is not just in the lung. It can occur in the airways. It can occur in your upper nasal passages as well as the upper airway passages. Next slide, please. So I'll just skip through this quickly, but I just want to use this to say that veterans have been identified with lung cancer for a long time. This was a study that looked at those that were identified in the system between 2010 and 2017. As you can see, overall survival is gradually getting better for these patients. In stage 1, it went from 58 to 68 to 68.4%. In stage 2, it went up again to about 50%. And also, even in stage 3 and even in the later stage 4s, we are able to show some improvement in these patients. And this is very encouraging news. That means that finding these patients is no longer a death sentence, is no longer something that we should ignore for weeks on end, because we have a lot of data that tells us that time to treatment is very critical in these patients. So our motto in the Florida Lung Health Coalition and Lung Health Coalition in general is to find them early and pass them on. That is essentially, in short, what we are here for. Next slide, please. So let's just quickly look at what some of the cutting edge technologies that are in practice today that are helping these patients. One is that AI in screening in the community is an extremely important tool. People who have deployed it countrywide, like in the United Kingdom and other parts of Europe, will tell you that without an AI-powered system, we are finding it difficult to keep up with the number of patients that are requiring first images, follow-up images, and how are we going to tackle this? So we have ways of enhancing patient encouragement and patient engagement, and to encourage them to undertake LDCT. There are outreach models out there that are allowing us to reach the correct population and allowing us to take that population and encourage them to attend LDCTs. So this can result in a pickup that is much more than standard ways of approaching these patients. So the pickup technology that we commonly use in practice today is natural language processing. And that is something that reads the radiology report, essentially picks out keywords and tells us that this is the way that we pick up both in the incidental and the screening population. We have one in our company, which is called Patient ID, and this has helped us over the years detect multiple patients with missed and overlooked lung nodules and other lung pathology. The disadvantages of this is that you can miss nodules. We can, pick up terminology is not the same all over, that radiologists often use their own terms, and this can be a problem. So thus a technology that can actually read the CT scan for you can be quite beneficial. Next slide, please. So that's how we started working with Radnet as well as their company Aidence in the Netherlands. And we started to integrate these systems into our PAC systems to tell us that we could discover lung nodules, etc. And I must say that they have been extremely successful in integrating this on a countrywide basis in the United Kingdom. And we have a lot to learn from those societies as to how we can do that in our own society. Next slide, please. So one of the areas that has been growing rapidly is to look at liquid biopsies. And by liquid biopsies, we mean that we take the peripheral blood and we test for enzymes, for molecular basis of cancer that we can find in the blood. Now, if you look at that, there are multiple mutations and fusions that are actionable that can be present in early stage lung cancers. So today we are even using liquid biopsies to show us what is the type of tumor, what are the actionable mutations, and how can we treat these patients better. So if you look at the left side of the screen, you see that in early stage lung cancers, there are multiple mutations and fusions that we can pick up both within the tumor, but not just within the tumor, but within the blood also. Next slide, please. So when we look at liquid biopsy in the lung cancer field, you have multiple companies in this field. It can get very confusing for people, etc. One is that for screening purposes, we have the multi-cancer screening tools that you must have read in the newspapers. You do a blood test and you can detect 50 cancers and things like that, which is true to some extent. However, the false positive rate is very high in these. So it can, we really don't know what the true value of this is going to be. It can lead to a lot of investigations that are not necessary for the patient. We don't want to send them down a path that the treatment is actually, sorry, the investigations are actually worse than the disease itself. There is also specific lung cancer screening, and this has been, various methodologies have been proposed here. These are much better because the false positive rates are lower and the false negative rates are extremely low. And that is absolutely critical for us, because then we can do a blood test and we can tell them, listen, if you have a blood test and it is negative, then you may not need an LDCT right now. We can safely wait to the next year for you to have another test and then tell you when we should have an LDCT. So essentially, some of these tests can act as triage tests. And this is something that is worthwhile investigating, because we proposed in the Lung Health Coalition that we could actually increase the number of total number of LDCTs. You have seen from previous slides from the other speakers that the rates of screening are so low. So if you can actually screen increase the screening numbers big time, then what you will find is that the total number of LDCTs that we are doing could actually be better if we are able to find other modalities to triage screening. And we are working on this through the Florida Lung Health Coalition in Pasco County in Florida. We can test for mutations for therapy. We can do all those other things in that previous slide. One of the ways that we can also use ctDNA and ctRNA to tell us as to how the patient is responding to therapy. That is the circulating tumor DNA and circulating tumor RNA. So these are all very, very exciting fields in the lung nodule continuum. And there is a lot more to come in this field. Next slide, please. So if you look at one of the ways in which we can screen these patients that have possible high risk for lung cancer, which are the USPSTF criteria that we have seen in these previous slides, you can find that the patients that are having lung cancer release not only full sequences of DNA in the blood, but they also release cell-free DNA fragmentomes, which are tiny bits of genetic material that are circulating in the blood. If we can actually pick them up and say that these fragments are those that are coming from tumors within the lung, then we have an effective screening tool. The other big advantage of using this is that we do not have to use next generation sequencing, which is expensive, which is about $2,500 minimum per test. But with these technologies, we are able to bring the cost down to between $100 and $200 per test. So it really starts to have an effect in the early stage screening process. So the idea would be, in the traditional route, which is on top of the screen, individuals at a high risk have an LDCT. But these patients usually have an annual non-invasive screening using blood tests, meaning when you go to your PCP and have your annual visit, or you can actually draw blood at a large, let us say, an American Legion function, for example. So you can then say that patients who are negative or have a low risk for the test can go to annual screening, but those that have an elevated risk go in for an LDCT scan. Next slide, please. And we know that early stage lung cancers can be detected using circulating DNA, but nowadays close to 50% of stage 1 lung cancers have got circulating DNA that can be detected. As you go to stage 4, look at it, 83% of patients have circulating tumor DNA. So this is going to be something that there's a lot of work going on, and we will be able to detect cancers better and better through blood tests. Next slide, please. Again, just to show you that patients who have circulating tumor DNA actually do much worse than those that do not. So it is also prognostic. So if you have an aggressive cancer, it could be that you're putting out ctDNA. Or if you have like one of those that Dr. Brandman showed you, that could be a slow growing or a in situ cancer, they are highly unlikely to have ctDNA circulating in the blood. So maybe as these technologies develop, we will be able to additionally, rather than just radiology, tell the patient, okay, you have a low risk and you can probably wait and have a screening next year. But these are the patients that have a high risk and you need to go in for biopsy and possible treatment. Next slide, please. You can skip this. You can go to the next slide. This is some of our data. We have now in our system, in my hospital, we have close to 400 blood draws in patients who have had some form of therapy for lung cancer. This is all early stage patients. Those that were what we call shedders, that is shedding ctDNA into their blood, about 71% of them we found have some form of actionable mutations that we can give to our medical oncologists and say, maybe these are the patients that you need to treat further and maybe after surgery, and maybe these are not. And if you're non-shedders, it is very unlikely, at least there is a 2/3 chance that you do not have lymph nodal disease. Next slide, please. We just look quickly at the field of procedural advancements. There's a huge amount of work going on here. The first and foremost, we have to take out less lung when we operate on these patients. One of those, we are working with this excellent company from the Netherlands again, that we call these deformable models. I keep them next to my robot and I use them because it gives me an exact anatomic representation of the patient just based on the patient's CT scan. So based on the CT scan, it recreates this 3-dimensional image for me, which I can also look through it through the robotic console. And it tells me that yellow is where the tumor is. It tells me where the blood vessels are. It tells me how I can see the bronchial anatomy, and thus I can do a better operation on these patients. I can plan my operations. So this is what is necessary so that we are able to do less and less for these patients. Right now, our Society of Thoracic Surgeons data for our institution shows that of all lung resections, those that are 90 years old to those that are 50 years old, we have a 48-hour stay after robotic surgical planned resections like these. And that is an amazing place to be. We need to get it down even further. I see a day in the future where it might be an outpatient procedure. So this is what we are slowly working our way towards. Next slide, please. So one of the major issues that we are working on is to reduce time to treatment. Time from diagnosis matters. The time from diagnosis to treatment matters. When you find them in the community, you find patients are wandering around for 2 months, 3 months, sometimes visiting various specialists, doing all these tests, etc., etc. And this does not bode well for patients. This is an older study from a Canadian center that says that the long-term survival, that is 5-year survival, is significantly impacted the longer the patients waited after diagnosis to have therapy. Next slide, please. So what we have is that we have these combined rooms where, to your left is the robotic console, and you can see the robot right there in front of you, the surgical robot. And as we turn, we have the bronchoscopic robot all set up in the same room, so that we provide diagnosis and treatment at the same sitting under one anesthesia for these patients. So when these patients are referred to us, we can do both of them together. So we do a combined event, and we have done close to 300 of these now in the hospital where I work. And this has reduced the time to treatment. We have the lowest in our system. Our time to treatment is down to 13 days now from the time the patient first as a mean, from the time the patient first presents to us to the time they get their definitive therapy. Next slide, please. This is just, we use augmented fluoroscopy that gives us almost CT type images. That may not be enough for accurate diagnosis, but is great for us to find these nodules and biopsy them, so we can use these in the operating room. Next slide, please. We can mark these tumors. Can you just go to the next video? So that is a small cancer in the lower lobe with the robot, and we have marked this using the robotic navigation systems. And through this, we are able to say exactly, we use ICG, and you can see how well it marks that tumor. It tells us where it is, and thus we can decide what kind of a resection we need to do. How can we save the more lung on this patient, etc. Next slide, please. Our combined, this was some of our earlier data. We have now doubled the number of patients. We have made sure that these patients are chosen appropriately. 96% of these patients have proceeded to surgery, so we do not need to cancel. The mean in-room time for this was very much an acceptable time. Next slide, please. We have proposed indications in which we can combine these treatments so that it is both patient-friendly as well as provider-friendly. Next slide, please. So I just want to end by talking about the Florida Lung Health Coalition. You know, our aim is very ambitious, and I request everybody to join us. We are not healthcare system centric. We are open to anybody. We are here to help people achieve a screening rate of 30% by 2030. And this is a very ambitious goal, but we are working on it. And I must say, since just 1 year of our founding, there have been many, many people who have given their time to help us get there. Next slide, please. Our priorities are we want to increase access to adults at risk, especially those that cannot afford it, or patients from minority populations that have a worse outcome. We are direct at-risk patient outreach with different methodologies. We realize that this is a community effort. This is not going to come from some ivory tower. So the PCP involvement is absolutely critical. They are our friends in this outreach, and we, they are our main focus from the physician community. State-of-the-art technology, patient navigation, fundraising to remove economic barriers, and finally, data collection. Next slide, please. So we have two pilot initiatives. One is a screening with blood test initiative in Pasco County. Our aim is to do this within a specifically defined geographic area. Pasco County, Florida has 500,000 residents, and so we know how many patients are at risk within that defined population. If our aim is to get the data from a single geographic region and show the powers that be in Florida, our leaders, that this is worthwhile doing in a single county in Florida. Thus, maybe they can expand it Florida-wide. The second is a pilot that is doing the same thing, but we are doing it to remove financial barriers in the east coast of Florida, which is the Treasure Coast. But there we have a traditional approach of removing financial barriers and reaching those disadvantaged populations to get them to do further LDCT related screening. And we have launched targeted outreach. We are working with primary care physicians. This is one of those sessions that we are reaching out to more physicians. We are trying to remove barriers to screening, which include fundraising, providing PCP orders, improving this whole shared decision-making business. How do we overcome the problems with that? Next slide, please. Thank you. Any questions? We are happy to entertain.
Thank you, Dr. Ninan.